Chris Preston with Idaho 2Fly.
And I'm Steve Draybeck with Idaho 2Fly.
Idaho 2Fly is an organization that supports men with cancer, and we started about 8 years ago. We're a volunteer organization, and most of our volunteers have a very personal interest in cancer, either because they have loved ones with cancer, they have cancer themselves, or in many instances, both of those things. If you know a man who has cancer, please refer him to us. We typically would do retreats, but COVID has kind of canned that for a while, and what we're doing now is Zoom meetings. Our Zoom support meetings really help men. They learn to articulate their feelings. We have facilitated discussions, and men, when they realize that everybody's in the same boat, communicate much more freely. Men need to know that they're not alone, and they need to know that their families are as affected by this cancer as they are, and that's some of the messages that we try to get across to them. Also, this is not just for fishermen, it's for any man who has cancer. So if you know of someone, please refer them to our website, have them give us a call. We'd love to help them out.
One of the projects we just started was develop a resource for men that have cancer. When I was diagnosed with prostate cancer, I had a lot of questions. Wasn't sure what prostate cancer was, what were the treatments, what were some of the things that I was going to go through trying to deal with this prostate cancer. And that was the reason that we decided to put together a video identifying some of the treatments and some of the things that men go through with prostate cancer, and hopefully answering some of those questions. We've partnered up with Idaho Urologic Institute and Dr. Waldman at that institute to present some information on prostate cancer. Dr. Waldman's going to give us some of the treatments that are involved with it, some of the upsides and downsides, and hopefully answer some of the questions that you may have on prostate cancer. Dr. Waldman.
Hello, I'm Dr. Todd Waldman, and I'm planning on discussing prostate cancer screening, and some of the challenges that go along with all of the above. Prostate cancer is the single most common solid tumor diagnosed in men in the US. It is something that affects up to 200,000 men annually, and between 20 and 30,000 men die from prostate cancer every year. So it is an important issue, and one of the issues that we face is that while screening for prostate cancer is relatively simple and straightforward, there are lots of men who, for whatever reason, don't end up getting screened for prostate cancer. Early diagnosis is important because it helps us identify men who need treatment early enough that most of them can be cured. What's involved with prostate cancer screening is two things. One is a blood test called a PSA, and PSA is a protein that's produced by the prostate, and we know what normal PSA levels are. Men who have PSAs that are higher than normal are more likely to have prostate cancer, and that's how it can be used as a screening test. The other aspect of screening is a digital rectal exam, so just a physical examination of the part of the prostate that we can feel. Part of what some of the myths, I guess, surrounding prostate cancer screening and some of the controversies have arisen because we know that there are lots of false positives when you talk about PSAs, meaning there are lots of men who have PSAs that are abnormal that do not have prostate cancer. And so some of the discussions that have occurred in the past and some of the recommendations that have occurred in the past have, I guess, fixated on that notion that we find a lot more men with elevated PSAs who don't have prostate cancer than we find men who do have prostate cancer. So as a result of this, about 10 years ago, there was a recommendation that came out by an organization that recommended against screening for prostate cancer. Their argument was that screening caused too much anxiety and complications around the process of making the diagnosis, and didn't really seem to have a great benefit when it came to saving lives. I think that virtually all urologists disagreed with those recommendations, and since those recommendations came out a little less than 10 years ago. That same screening task force, it's called the U.S. Preventative Services Task Force, has since changed their recommendations, and they do now favor prostate cancer screening after having discussion with your physician. The reasons that they've changed their screening is they broadened the information that they looked at when they decided to make their recommendations, and they realized that there is evidence that we do save lives. And if PSA and exam is used judiciously, we don't cause excess difficulties or anguish for patients who have elevated PSAs. When men have their PSAs drawn, it's important not just to have a single PSA drawn, but to have their PSA done annually. One of the things that we look at is not just the absolute value of the PSA, but the trend and the changes that occur in the PSA over time. That is something that can be useful when trying to gauge someone's risk for having a prostate cancer. Another part of the recommendation, besides just what's involved with the screening, is who should be screened. And currently, the recommendation is for men generally beginning at the age of 50, and that they have annual screening through the age of 75 or 80. There are exceptions to this, and that would be men with a significant family history of prostate cancer, someone who has either a brother or a father or several uncles that have prostate cancer. They should begin getting screened earlier, either at age 40 or 45. African Americans are another group of individuals who need to be screened earlier, again at age 40 or 45. And that's because their risk of prostate cancer is higher than other groups. Once someone has a PSA or an exam that is considered concerning enough that prostate cancer is at least suspected, or there's enough concern for prostate cancer, that's when we attempt to make a diagnosis and to either rule in or rule out prostate cancer, and that's done with a biopsy. A prostate biopsy is a short procedure that's done in the office. What we do is we perform ultrasound of the prostate transrectally. So an ultrasound probe is inserted into the rectum. We can see the prostate. You can use the ultrasound to inject local anesthesia to anesthetize the prostate and make it numb. And we then use the ultrasound to pass a needle into the prostate, that each time it passes into the prostate, it takes a small sliver of the prostate. That's how you get the biopsies. And most of the time, we do between 10 and 12 biopsies. So we sample throughout the prostate and make sure that we're going to identify any significant cancer that's there. A tool that we sometimes use in conjunction with biopsies is an MRI of the prostate. Generally, that's done prior to the biopsy. MRI is a way to potentially identify any lesions that might be suspicious for cancer, localize them, and then use the ultrasound and biopsy to make sure you sample that area that's abnormal. When men have prostate biopsy, significant complication rates are very low. The most worrisome complication is infection, and that happens about 2 to 3% of the time when patients have prostate biopsy. We have patients take some antibiotics and do a couple other measures to help prevent infections, and that usually works fairly well. Bleeding is very common after a prostate biopsy, but that bleeding is annoying. It is not dangerous. Significant bleeding complications are exceedingly rare after prostate biopsies, a fraction of a percent. Men who have a biopsy need to limit their activity the day of the biopsy, but they're back to normal activity the following day without needing any pain medication or anything afterwards. Once someone has a biopsy, if the diagnosis of prostate cancer is then made, then there are multiple factors that we use to kind of evaluate the cancer and make a decision about how best to handle it. And the ways that we handle prostate cancer can be anything from just monitoring it to more aggressive treatment, including radiation therapy, surgical removal of the prostate. There are some other sort of less conventional ways to treat prostate cancer as well, including freezing the prostate, that's called cryotherapy, HIFU, which is high intensity focused ultrasound, which is a way of administering heat to the prostate. How a given person's prostate cancer is best managed depends on the type of cancer, its volume, the severity, the grade, and that individual's overall health. Generally, men in poor health or older men require less aggressive treatment or no treatment at all, because prostate cancers, most of them tend to grow pretty slowly. And in those cases, we tend to watch the cancer and just keep tabs on it and make sure it's not progressing quickly enough that they would need treatment. For younger men with moderately aggressive or more aggressive prostate cancers, those are the patients that we treat more aggressively with surgery or radiation. There are pros and cons to both surgery and radiation, and they each have approximately equal efficacy when you talk about chance for curing the prostate cancer. So again, the decision about how best to treat a prostate cancer really boils down to a discussion between the patient and his physician, and the advantages and disadvantages to the various options. And everybody's different. Everybody's prostate cancer is different, and there's no one size fits all option. When it comes to making the decision about treatment, obviously this discussion would occur between a patient and his urologist, but some of the things that influence how patients decide to proceed are what is involved with the treatment and what the potential side effects are. When it comes to radiation, the most common way radiation for prostate cancer is performed is external beam radiation therapy. And what that means is focusing radiation on the prostate from an energy source that is administered exteriorly. The shape of the beam that is administered to the prostate is tailored specifically to each individual, and there's a lot of high-tech physics that goes into that. The radiation is administered over a series of treatments over several weeks, and there's at least a couple different treatment schedules. That schedule might range between 5.5 and 8.5 weeks, 5 days a week. What most men experience during the time that they're undergoing radiation therapy for prostate cancer is some mild fatigue. It's common to have some urinary frequency. It is also common to have more frequent bowel movements. Some of the concerns that patients have when they hear radiation therapy about your hair falling out or nausea or feeling ill, those just don't occur with radiation therapy for prostate cancer specifically. Another way of administering the radiation therapy is called brachytherapy, and that is where small radioactive seeds are placed directly into the prostate. That procedure is not done nearly as commonly as standard radiation therapy, especially here in Boise, and that is partly historical reasons. Most urologists here don't really do much brachytherapy. Part of it is that brachytherapy is no more or less effective than the standard external beam radiation therapy for prostate cancer. Side effects with the brachytherapy are mostly confined in the short term to urinary symptoms. It tends to have more of an effect on urinary symptoms in the short term. Both standard external radiation and brachytherapy have few long-term urinary related symptoms. Incontinence or bladder control problems would be a very rare complication of either form of radiation therapy. Neither form of radiation therapy has any short-term effects on erectile function or sexual function over the medium term, so 4 to 5 years post-treatment. 25 to 30% of men who've had radiation therapy will develop more problems with erections. Men who undergo surgery for prostate cancer, the vast majority of the time that surgery is done robotically, and that what robotic surgery is essentially laparoscopic surgery, so it's surgery done through several small incisions instead of one big one. The robotic aspect of it is a device that gives the surgeon a 3D image instead of looking at a flat screen, and gives the surgeon instruments that articulate and are much more, you can make much more precise movements and precise dissection of tissues with that. It requires an overnight stay in the hospital, requires a catheter in your bladder for 1 week, and you're limited to no heavy lifting for about 6 weeks post-surgery. Most men who are still working go back to work in a week or two afterwards. And most men don't take prescription pain medication after they leave the hospital, or if they do, it's only for a day or two. The issues in terms of complications that we worry primarily about with prostate removal are incontinence and erectile dysfunction. Most men experience both of those. The incontinence or problems with bladder control is a long-term or permanent problem in only about 5% of men. So most men get their control back within a few months. Most men have most of their control back within a few weeks, and it tends to be kind of a mild nuisance rather than a life-altering problem during those first few weeks after surgery. Erectile dysfunction is a little bit less predictable in terms of how likely it is to recover erections after surgery, and there are multiple factors that influence that, including other health problems, quality of erectile function before surgery, and whether or not a given person's cancer makes it safe to try to preserve the nerves that are responsible for erections. And those are all topics and discussions that are best had between a patient and a surgeon preoperatively. Once most men have gotten through the initial few weeks after their treatment, they are, whether it's radiation therapy or surgery, their lives are essentially normal, with the exception of those potential mildly annoying complications that may occur in the short term. But they feel otherwise very normal pretty quickly after either form of treatment. I guess one of the other topics that sometimes does come up when you're talking about prostate cancer is additional treatments. So sometimes when men are diagnosed, they do not have a prostate cancer that is confined to the prostate, and they have prostate cancer that is spread somewhere else or metastasized. Men who have metastases and men who develop recurrence of their prostate cancer after either surgery or radiation often need additional treatment. And there are lots of things that we do to treat prostate cancers in those situations. Usually the mainstay of that treatment is something called hormone therapy. And what we mean by hormone therapy when we talk about prostate cancer is to treat men with something that stops their body from producing testosterone. Prostate cancer cells thrive on testosterone. Testosterone is the normal male hormone, and we can give medication that shuts off the body's testosterone production temporarily. When we do that, the prostate cancer stops growing, the tumors shrink. It is not curative, but it slows the cancer down for a long period of time. That does have side effects associated with it, and all of the side effects are related to what men feel like when their testosterone is low. And the most common symptoms that men experience when they have very low testosterone is fatigue. They experience hot flashes, just like women get when they go through menopause. And they tend to lose muscle mass. Sometimes the hormone therapy alone is not enough, or the hormone therapy becomes less effective over time. And in that case, there are additional newer treatment options that we have, including some targeted radiation therapy to the bones. There are some oral medications that take advantage of some of the mutations that prostate cancer cells undergo. There's immunotherapy that we use for prostate cancer. All of those things are options for treating more advanced prostate cancers as prostate cancer becomes less responsive to the hormone therapy. And it has become much more of a chronic disease for most men than it is a fatal problem, even when they're diagnosed with metastatic prostate cancer. The real point, though, is probably to avoid a situation where you have metastatic prostate cancer, and the best way to avoid it is with early detection, and that's why screening is important, and why it's important to have a discussion with your physician about screening for prostate cancer. And hopefully, if anyone is to develop a prostate cancer, it gets identified early enough that it can be successfully treated and avoid having it progress to something more serious. Thanks for your time.